Good morning. It's really my pleasure to be here to present to you as part of the Cardiovascular Care for Women course on behalf of Harvard Medical School and the Mass General Corrigan Center. So I'll be speaking on microvascular angina and the role of cardiac stress PET, or positron emission tomography. And my name is Viviani Ticchetti. I'm the director of the Cardiac Stress Laboratory at Brigham and Women's Hospital. These are my disclosures. I have no relevant disclosures to this talk except for research grants. So the learning objectives of today's talk are really to, one, recognize limitations in conventional diagnostic and management approaches for stable ischemic heart disease, particularly relevant in women. Secondly, to describe how novel imaging tools are being used to understand prognosis of diffuse coronary artery disease and coronary microvascular dysfunction in symptomatic patients. And we'll be focusing on stress cardiac PET. And three, to consider management implications of stable ischemic heart disease and coronary microvascular dysfunction in specific populations, especially women who have a very high burden and prevalence of metabolic disease, non-obstructive coronary artery disease, as well as heart failure with preserved ejection fraction. And you'll see how these are relevant to microvascular angina. So many of you are aware that we've been privileged to have a real lifetime of cardiovascular advances, which reflect the steady decline in cardiovascular deaths over at least the last 50 years, and can be quantified in terms of some major medical and scientific advances, including the definition of risk factors in the early 1960s, the first description of bypass surgery later in that decade, and then subsequently, development of coronary angioplasty, the device therapies with the implantable cardioverter and defibrillators. But along with this came a refined ability for us to also non-invasively probe cardiovascular disease processes and diagnosis. So starting again in the 60s with Bruce protocol treadmill testing, followed by the advent of nuclear stress testing in the 1970s, with positron emission tomography beginning in the 80s, as well as stress echocardiography. More recently, cardiac MRI and viability studies, as well as coronary CTA, are really revolutionizing the landscape of our tools for probing cardiovascular disease. And really, in clinical diagnostics and imaging, we capture infinitely more data than are currently integrated into daily practice. Many of you are very familiar with this, from the humble stress electrocardiogram as patients exercise on a Bruce treadmill protocol, for example, to two-dimensional echo, including more recent techniques with strain imaging on echo, cardiac MRI, and the ability to quantify small areas of scar using late gadolinium enhancement, and then nuclear cardiology techniques, including the ability to both assess cardiac perfusion and metabolism. And then along with that, looking at anatomic assessments with coronary CTA. The question really is, can we harness all of this amazing technology to better inform patient care and outcomes, particularly as relates to what I consider one of the largest patient populations that's a specific precision medicine approach, which is our female population, which has really been underrepresented in terms of research, focused research in the cardiovascular space for many years, as you've already heard. So we know that cardiovascular disease remains the #1 killer in both women and men. And in fact, despite all of the progress that I just reviewed, there may be some concerning epidemiologic trends that are visualized in this slide, which show the latest data from the American Heart Association and reflect possibly a slight uptick in the cardiovascular mortality trends that we have observed over the last several decades. And perhaps that reflects the fact that cardiovascular disease as we know it is changing. Angina and dyspnea remain very common presenting complaints, But for up to half of patients who are actually seeking an explanation for their symptoms in the catheterization lab, no obstructive coronary artery disease is found. And this is shown here in a contemporary registry of over 11,000 patients in Denmark who were referred for invasive angiography. And you can see that in a third of the men and 2/3 of the women had no obstructive coronary artery disease. And yet we know that angina without obstructive CAD portends a poor prognosis in both women and men. So I would posit that, perhaps designed for the identification of obstructive CAD, a lot of the conventional approaches that we have used for diagnostic testing in stable ischemic heart disease and cardiology in general can lead to actually over-testing some patients without truly differentiating those who are at risk. And that's because obstructive CAD is really but one phenotype of coronary artery disease and dysfunction. And if you consider the tip of the iceberg being the obstructive coronary artery disease phenotypes, which we can capture very easily using, coronary angiography, now both invasively and non-invasively, what we don't see are all of the diffuse arterioles and smaller vessels of the heart that are below the resolution of the X-ray, and yet contribute the vast majority of the resistance in the circuit of the heart circulation, and certainly can contribute to poor outcomes. So beyond obstructive disease, diffuse non-obstructive disease, and then coronary microvascular dysfunction can also play an important role in defining patients' symptoms and also their outcomes. But in order to probe these different processes, we have to use different tools. And so certainly at the more proximal end, looking at gross differences in regional wall motion as well as perfusion defects, as we have done with our traditional types of strategies, including stress echocardiogram and cardiac stress perfusion, myocardial perfusion imaging with both SPECT and PET in the past. But more recently have come to learn that there's actually potentially a very large patient population who are at risk or who already manifest coronary microvascular dysfunction. And this is a very heterogeneous patient population, as you'll learn, and for which we need specialized tools to really probe the microvasculature, including through impaired coronary flow reserve and other ways that we can measure using PET and other techniques, as we will review. So in patients with refractory angina, despite non-obstructive disease, or even some of those who've already had optimal revascularization, coronary microvascular dysfunction may actually be the culprit. So how do we evaluate coronary microvascular disease? Well, as I mentioned, the coronary microcirculation is really too small to be directly imaged in vivo. And so it must be evaluated indirectly by perturbing function. And we can do that through a variety of techniques, including classically invasive techniques, which measure coronary flow reserve invasively, as well as the index of microvascular resistance. But more recently, we've been able to apply newer computational approaches to non-invasive techniques. And the gold standard of doing this is really through PET, or positron emission tomography, which also allows us to measure a non-invasive coronary flow reserve. Recently, the Covadis group published clinical criteria for suspecting coronary microvascular dysfunction, and it boils down to three major concepts. So the first, patients should have symptoms of myocardial ischemia. Secondly, they should have absence of obstructive or flow-limiting coronary artery disease through some anatomic assessment, potentially even with a functional assessment, such as fractional flow reserve, which you'd want to see greater than 0.8 to be normal. And then third, some demonstration that's objective of impairment in coronary microvascular function. So a coronary flow reserve of less than 2, an index of microvascular resistance greater than 25, or evidence of microspasm. So to focus a little bit more on this measure called coronary flow reserve, or CFR, I'll take you through what it means. And so very simply, it measures the integrated hemodynamic effects of epicardial CAD proximally, as well as more diffuse atherosclerosis, vessel remodeling, and then downstream microvascular dysfunction on myocardial tissue perfusion. And it really just refers to a ratio of myocardial blood flow that we can quantify at peak hyperemia or peak stress, like we do with a vasodilator infusion non-invasively, over that at rest. So with a cardiac PET protocol, which we carry out routinely at Brigham and Women's Hospital as part of our typical stress testing modalities, what you can do is that in 2 10-minute exams, you can get information from the static pictures on regional myocardial perfusion defects that lets you quantify the amount of LV ischemia or scar. You can get the ECG gated or functional information that allows you to quantify the ejection fraction at rest and stress. And then you can also obtain the flow quantitative myocardial blood flow information in the dynamic pictures, which again, we can quantify in mils per minute per gram of myocardial tissue, both in the rest conditions as well as in stress. And we can integrate that over the entire coronary territory for each of the main coronary territories, and then average that over the whole left ventricle. So you can see in this patient that they had normal perfusion, they had a normal ejection fraction at 60+%, and they actually have normal coronary flow reserve because they can more than double their blood flow from rest to stress conditions. And their flow reserve here was quantified around 2.2 without much regional variation between coronary territories. And our data, as well as that of multiple other groups now from prospective registries, have demonstrated the risk of coronary flow reserve by categories. So their risk of cardiac mortality by categories of coronary flow reserve. And you can see that patients who can at least double their blood flow from rest to stress and have a CFR of 2 and above actually have a significantly lower annualized cardiac mortality than those whose flow reserve values are less than 2. And you can see an inflection point that you start to see around values of 1.8 and below, and subsequently 1.6 being quite severe, where you start to see a doubling and more of the annualized cardiac mortality risk. And now your flow reserve can be reduced because of obstructive CAD, diffuse CAD, microvascular dysfunction, or a combination of all three. And that's why excluding obstructive CAD through some anatomic assessment is important to truly diagnose microvascular dysfunction in the absence of concomitant obstructive disease. We've also shown that this risk is independent of traditional measures of LV ischemia globally and ejection fraction, as well as obstructive CAD. And you can see here in patients who underwent both cardiac stress PET non-invasively followed by cardiac catheterization, and this scatter plot basically shows that even in patients who had pretty non-significant coronary artery disease or non-obstructive disease, here a CAD prognostic index score of 0 meant plaques less than 50% in diameter. There's actually quite a range of global coronary flow reserve values in that patient population, suggesting that you don't have to have obstructive disease in order to have impaired flow reserves. And those are the patients who have a more true form of microvascular dysfunction and or diffuse atherosclerosis. And independently of obstructive CAD, those patients who have a very low flow reserve are at high risk for events. Impaired flow reserve also interacts with myocardial injury or a positive troponin, even at low levels, to modify risk in patients who otherwise are pretty low risk. And you can see that in this cohort of patients who had otherwise completely normal perfusion and essentially ruled out for an MI when they came in to the hospital, but were subsequently referred for clinical testing non-invasively to rule out ischemia, you can see that even the patients who did not have any ischemia on traditional measures and had normal EFs, for those who had a tiny detectable troponin and a low flow reserve, those were the patients who were truly at highest risk. And this also corresponds to a same patient population who also manifests low CFR and diastolic dysfunction. And it turns out that if you have both impaired flow reserve and elevated E over E primes, which correlate non-invasively with invasive cardiac pressures, those patients have more than a five-fold increased risk of presenting with subsequent heart failure events that are almost all HFpEF events because we excluded patients with low EF in the study. And coronary flow reserve can also reclassify risk in diabetic patients such that those without known CAD, but who have diabetes and have a low flow reserve are at much higher risk for cardiac mortality, similar to those with known CAD, as opposed to those without CAD, but who have diabetes and have a preserved coronary flow reserve, who have a very low risk of events. So again, reflecting that diabetics are a very heterogeneous patient population, but if you add in coronary flow reserve, you can much better risk stratify their cardiovascular disease risk. And CFR is also associated with worsening BMI, such that patients in the more obese, severely obese, and morbidly obese categories start to see substantial declines in their coronary flow reserves and increased risk of microvascular angina and dysfunction. All suggesting that perhaps we can use this tool to better phenotype risk in patients who otherwise have quite a heterogeneous risk pool for disease. And this is particularly evident in women, as I mentioned, who are at high risk for diabetes and insulin resistance, obesity, and also non-obstructive coronary artery disease, as well as heart failure with preserved ejection fraction. We know from non-invasive data that in symptomatic patients, coronary microvascular dysfunction is quite prevalent. So these were patients who were referred for cardiac stress PET. There were over 1,200 patients who had a completely normal perfusion study. So again, would otherwise have been considered a completely normal stress test. 2/3 of these were women because more commonly, women don't manifest the large regional ischemic abnormalities because they're less likely to have obstructive CAD, as I reviewed in some earlier data. And so what we found is that in both the men and the women, about 50% or more of these patients actually manifested a CFR of less than 2, which could explain their symptoms. And in those who had a low flow reserve, their risk of major adverse cardiovascular events was significantly higher. So this is a phenotype that's prevalent, particularly in women, even though when the flow reserves are low, both men and women do poorly. It has also been shown in invasive coronary evaluation for patients. And so these are data from the CORMICA study, as well as another study from Suda et al., both published in JACC, that showed that for about 40 to 50% of patients who are referred for invasive evaluation, up to, as I mentioned, 40 to 50% have no obstructive disease, which is further well-defined by also having an FFR of greater than 0.8. So these are truly patients who are symptomatic, referred for invasive evaluation, but then who don't have flow-limiting or obstructive coronary artery disease. And it turns out that the vast majority of these patients have some form of coronary vasomotor dysfunction, and most of that is actually from coronary microvascular dysfunction, with a minority being pure vasospasm. What I find really interesting is that when severely impaired, coronary flow reserve may be even more prognostically important or significant in women. And that's shown in these data here, where, as I mentioned, flow reserves around 2 are quite prevalent in both men and women. In fact, if flow reserves are less than 2, that's when risk starts to go up. But if you stratify by sex, it actually turns out that that risk is not the same in both sexes. And in fact, for patients who have really low flow reserve in the severely reduced categories, the women seem to do significantly worse. We don't know why that is the case, but we know that a big difference between the women and the men, even those who have a severely impaired flow reserve, is that the women, again, are more likely to have non-obstructive disease, whereas the men are more likely to have multivessel disease. And so a lot of these patients go on to have coronary artery bypass and other forms of revascularization that the women with impaired flow reserve and no obstructive disease or single vessel disease just aren't candidates for. So it's certainly possible that we're modifying risk in patients who have really low flow reserve from obstructive etiologies, namely in the men, but that we're not necessarily impacting that impaired flow reserve risk in the women who have more non-obstructive disease. And what should we be doing in terms of what is guideline-directed medical therapies in those patients? So we'll talk about that in some cases to come. So here we go. Case 1, a 67-year-old woman with obesity, diabetes, hypertension, and coronary artery disease who had previously had a percutaneous coronary intervention or stent to her RCA 3 years ago, came back to the clinic with recurring exertional angina and dyspnea symptoms. She described that she could no longer walk upstairs without experiencing some chest pain, which seemed fairly typical. It was improved by rest and sublingual nitroglycerin and had been worse over the preceding few weeks. Her current medical therapies included a low-dose aspirin, rosuvastatin, clopidogrel, labetalol, isosorbide, and insulin. Her ECG showed no acute ST segment abnormalities. Her echo was described as having poor windows, but with mild LV hypertrophy and an EF of 65%, as well as grade 2 diastolic dysfunction. She'd had a vasodilator SPECT 2 weeks before, which showed normal, completely normal myocardial perfusion imaging with no ischemia, no scarring, and a normal EF. So she was referred for a vasodilator PET to look at, again, regional areas of ischemia and potentially also quantify her blood flow reserve. So what these pictures show, and you can see the stress row on the top, followed by the rest row on the bottom with the short axis pictures going from apical to base. In the top set of pictures, in the middle, the HLA or horizontal long axis, and in the vertical long axis views, is that you can see a medium-sized perfusion defect, mostly along her apical inferior, as well as the mid anteroseptal and infroseptal segments, with some transient ischemic dilatation that you can appreciate as the inner cavity size increases from rest to stress, which shouldn't be the case. And in fact, her PET coronary flow reserve values showed abnormal, both regional as well as global rest and stress flows, with a global coronary flow reserve of 1.4. So that would put her in the severely reduced category. So her clinicians, because they couldn't exclude obstructive disease given her regional ischemia and given her diffusely low flow reserves, recommended doing an invasive coronary angiography to, again, exclude anything that would be fixable through a further revascularization procedure. And what you see both in the left side as well as the right-sided coronary views is that she had patent epicardial coronaries without flow-limiting stenoses. She did have, you can see a mid-RCA lesion here, but the FFR was 0.88 or normal, and so not flow-limiting. And clearly she has diffuse atherosclerosis, but nothing that could, at least at the epicardial level, be fixed and improve her symptoms. So how do you manage this patient? And so, this is something that we're starting to see more and more as we utilize this technique called PET, and are starting to gather data in terms of how to think about these patients, because when they've got diffuse microvascular dysfunction, probably in the setting of diffuse non-obstructive coronary artery disease, Any focal fix with revascularization is not an option. So how do we aggressively manage these patients in order to minimize both their symptoms currently with anti-anginal therapies, for example, as well as their long-term cardiovascular risk with aggressive statin therapies for stabilizing plaque and potentially inflammation. And then furthermore, in a diabetic patient, we have some opportunities as well with dyspnea and potentially with HFpEF. We have some opportunities to impact her prognosis with newer therapies like SGLT2 inhibition, potentially even in the setting of morbid obesity, consider bariatric surgery, et cetera. And so these are some of the management strategies that we're starting to study now that we can define microvascular angina and coronary microvascular dysfunction in these patients. Case 2 is a 63-year-old woman with hypertension, a positive family history of early CAD, who presented with recurrent exertional chest pain when she felt particularly upset and stressed. Her ECG in the clinic showed no acute ST segment abnormalities, and she actually underwent a exercise treadmill test on a Bruce protocol where she exercised for 11 METs, which is pretty substantial, and stopped for fatigue, but not for any of the exertional chest pain symptoms that she'd been feeling, and had no ischemic ECG changes. However, her provider also obtained a coronary artery calcium score, which showed a calcium score of 256, which for her age and sex demographic is actually in the 95th percentile. And she had a substantial burden in the LAD territory and a bit as well in the RCA. So this prompted a coronary CTA where, in addition to the simple scan that's done for coronary artery calcium, which doesn't use contrast, the coronary CTA uses contrast to actually look at the patency of the luminal coronary arteries, much like an invasive coronary angiogram would do. And it's a particularly sensitive technique. And what we see here is that they found a moderate stenosis in the mid-LAD territory in that 50 to 69% range, which is because of the sensitivity of this technique and the sometimes overestimation of any plaque may or may not be flow limiting or obstructive, because this is purely an anatomic assessment and it's not a functional assessment. So her providers referred her for a vasodilator PET perfusion study to assess the functional significance of that moderate LAD stenosis. And what you can see from her pictures is that she had completely normal perfusion on PET. And then furthermore, in addition to her normal EF, she had completely normal coronary flow reserve values, both regionally as well as averaged over the LV. Her CFR value was 2.8, so very much in the normal category. And then you can see that with the PET CT, we obtain a CT for attenuation correction, which allows us in some patients to do coronary artery calcium scoring. In her case, she already had that, but you can appreciate, the calcium, especially in that LAD territory. And so she was managed with preventive therapies, including low-dose aspirin, high-intensity statin, and her symptoms ultimately resolved. So this slide summarizes an extended algorithm of diagnostic testing strategies in patients with suspected ischemic heart disease. And what I would emphasize is that whether a functional or an anatomic strategy is pursued first, unexplained symptoms in patients, particularly in a certain demographic, and I would include women in this, merit consideration of testing for coronary microvascular dysfunction, because as we reviewed, it's quite prevalent. So in summary, how do we incorporate flow reserve values, such as those from PET, in prognosis and therapy of our patients? Well, if the flow reserve is preserved or greater than 2, then the prognosis is generally good, and high-risk angiographic disease is unlikely. But if it's not, then 2 scenarios are possible. Even in those who have unlikely presence of coronary artery disease that's obstructive or high risk, we have to think about how to mitigate outcomes. And so in those who have a high risk of angiographic disease that's present, namely through subsequent testing with cath or an anatomic assessment non-invasively, then we know that certainly guideline-directed medical therapies are important in those patients, plus or minus revascularization, particularly for symptoms in stable ischemic heart disease. And those patients tend to be male, actually. And then in the other category, where high-risk angiographic disease is absent, but patients have low flow reserves, then again, we have to think about guideline-directed medical therapy in those patients who tend to be more likely to be women and actually have a high prevalence of low flow reserves with non-obstructive disease in women. And this really begs the question, what is optimal revascularization in the patients on the left? Is CABG better than focal stenting, for example? And then more relevant for this talk, what is guideline-directed medical therapy? And what does that actually mean when guidelines do not currently consider coronary microvascular dysfunction testing, although that's been recently changed for the European guidelines, where it's either a 2A or a 2B classification, depending on the modality. But even within that, we're still learning how to incorporate these techniques so that we can get high quality, large data sets and potentially trials to better understand what could be evidence-based therapies to manage these patients. So the takeaway points from today's talks are, one, that focus on obstructive CAD and HFrEF are no longer adequate. And that's because coronary outcomes, cardiovascular disease outcomes, are impacted not just by the macrocirculation, but certainly also by the microcirculation. Two, effective diagnostic testing needs to identify patients who are at high risk of events in general, and not just who are at high risk of anatomically obstructive CAD per se, like the old Diamond Forrester classifications. But without over-testing the patients who are truly at low risk, and an aid in the development of needed evidence-based strategies for their management. So along with this, what we've been discussing is that if we change the conceptual model of the prevalent pathology and the phenotype to go from obstructive anatomic disease, as is very common in males, to actually consider abnormal flow reserve or impaired functional testing that takes into account the whole coronary circulation, then what you actually see is that for both women and men who have a low flow reserve, they have increased risk of events. But in men, that's more likely to be mediated by obstructive disease, for which we have terrific revascularization strategies. In the other group of patients who have very low flow reserve or vascular dysfunction, but in the absence of multivessel obstructive disease, we really haven't been testing therapies in this group to try to mitigate their high risk. And this is what is particularly relevant for our female population. So we and others tried to put together some top priorities for cardiovascular imaging considerations in women. And one area to emphasize that's relevant for what we've been discussing is really we need to leverage newer technology to probe relevant biology in women and invest in subsequent research and clinical trials. So finally, the last takeaway point is that characterization of the underlying pathophysiology is truly necessary to better, one, diagnose disease, two, define prognosis, and three, tailor new management strategies to individual patients, particularly our female patients. So when we consider all of the pathophysiology that's linking coronary microvascular dysfunction and adverse events, a lot of it's very relevant for females. When we consider the prevalent risk factors like obesity, hypertension, diabetes, CKD, chronic kidney disease, coronary artery disease, how that may impact upon low-level ischemia at the microvascular level, which may lead to impaired flow reserve, cardiomyocyte injury with troponin elevations that are low, and fibrosis, diastolic dysfunction, and ultimately HFpEF and other outcomes, including death. whether or not patients manifest obstructive disease. And we have all kinds of tools that can actually probe along every step of this process. So the future, when I think about, is actually quite exciting because we have to consider the role of the coronary microcirculation in macrovessel disease, because this will hopefully impact and improve our ability to diagnose and clarify prognosis in patients, and then hopefully avoid costly, unnecessary, and potentially harmful tests, and better define a population that we can subsequently define evidence-based strategies for management. So with that, I'd like to very much acknowledge all of my colleagues who are terrific and have put together this amazing program today. Dr. Nandita Scott, Dr. Melissa Wood, and Dr. Doreen DeFaria as part of the Corrigan Minahan Heart Center. And I'm certainly happy to take any questions during our panel session. Thank you very much.